today's session is start the recording. We're also going to pop up a poll while we wait for the rest of the audience to join us. So as we just give it another couple of minutes, you should see a poll coming up on your screen. We would love to know what state you represent. So we'll give that just a moment. There's our poll now. So if you could take just a moment as you're joining to let us know what state you're from, we'll get started in just a moment. And if you're just now joining us, you'll see a poll up. We ask that you make your selection of what state you're joining from while we wait just another minute for others to join us. We'll be starting shortly. Please take just a moment to let us know what state you're from. Okay. I think we'll go ahead and get started. Thank you so much to our producers for having that up. My name is Deb Dillingham, and I'm the Senior Director of Cancer Control Strategic Partnerships here in Ohio and West Virginia. We're so pleased that you're joining our event today. Welcome. We will have several polls, as you just saw, throughout our presentation this morning, and we ask that you complete those as they pop up because it will give us very, very timely information. We do ask also that if you called in from a phone, that you please enter your name and your organization in the Q&A, so we do have record of your attendance. All lines will be muted during this program, and we ask that all questions be entered into the Q&A tab on your screen. If we have time at the end of our sessions, we will be taking questions live, but to ensure you have an answer, please do enter those in the Q&A and in the chat. We will work with the presenters post today's presentation to get those questions answered for you. I now have the pleasure of introducing our welcoming speaker, Dr. Kamal. Dr. Kamal is the inaugural Chief Patient Officer of the American Cancer Society and Consulting Associate Professor of Medicine at Duke University. He's an internationally recognized thought leader and health services researcher with particular expertise in the delivery of high-quality supportive and palliative care to patients with cancer and their caregivers. He's published over 200 peer-reviewed manuscripts in JAMA, Annals of Internal Medicine, and Journal of Clinical Oncology, and has been quoted or featured in USA Today, National Public Radio, Forbes, and many others. Dr. Kamal completed his internal medicine residency training and hospice and palliative care medicine fellowship at the Mayo Clinic in Rochester, Minnesota, and hematology oncology fellowship at Duke University. He holds a master's in health sciences and clinical research from Duke University and a master's in business administration from the University of Massachusetts at Amherst. I now turn the program over to Dr. Kamal. Welcome.
Thanks so much. It's really an honor to join you and to be in the company of so many people who really take part the importance of health equity, particularly in colorectal cancer, and the hard work that has to be done to ensure that all populations of people, regardless of where they live, their backgrounds, what they look like, where they work, and who they're around, to have access to high quality care. As was mentioned, I am an oncologist and a palliative care physician, which means oftentimes people think that I focus on sort of late line treatment and management. And I think, obviously the best palliative care is not getting the disease in the first place. And so when we think about colorectal cancer as an entity, we think about so many areas of gaps and important areas of interventions, right, where we have to think about. Because it's Colorectal Cancer Awareness Month, I've had an opportunity to do a few different interactions with media nationally and some parts of a listening tour to just understand where are some of these barriers. And I'm going to reflect back to you barriers I know you already know, but that I'm learning along the way. And we recognize, for example, that patients and their caregivers don't read the same literature or medical textbooks that we read as clinicians and administrators and thought leaders in this space. And so oftentimes this gap, right, sort of the knowing and doing gap, right? We know what the right thing is to do, but getting it done, particularly in populations where frankly, they're very busy doing other things, as we all are, or may have important education or educational or engagement barriers to intersecting with these services, is really important for us to understand, and frankly, to continue to be humble about. When I work with oncology fellows and residents and others who are learners, what's really important is to always have a sense of curiosity, because curiosity slows down the process of jumping to some sort of judgment. And curiosity is a really good speed bump along that way, because it keeps us from early closure, where we think that maybe we know why something is happening, or importantly, why it's not happening. And if we stay humble and curious for a moment, we can ask questions like, I wonder why, despite the fact that we did this educational intervention, that our rates of colorectal cancer screening did not go up. I wonder why, despite this, that, and the other, that some things are not changing. That level of curiosity is how we're going to solve important problems like this, right? And remaining humble to the fact that there are lived experiences that people have that serve as important barriers to accessing care that we may not understand at all. My lived experience is, I grew up in a small town in Missouri, so not all that different, I think, than where you guys are coming from, right? In a small town of 15,000, and I can tell you, as I grew up, though my parents were very educated, they weren't physicians though, they were college professors, that we ourselves face as a family important barriers in terms of, how do I access the health system? How do I make sure that the language being used is non-medical? How do we think about shared decision-making, where healthcare is not done to a person, but with a person? How do we use the appropriate and inclusive language? For example, I'm trying to socialize within our own organization, right? The idea that it's not cancer patients, it's people with cancer, right? That fundamentally we're acknowledging their personhood first, and that we're not defining a person by their problem list or the disease by which oftentimes clinicians would think about, right? And so when we identify personhood first and foremost, we recognize that as we see people as people, which from my perspective are human beings who are just trying their best, we recognize that the barriers that are getting in the way are despite people trying to do their best. And being humble to that fact really, I think, opens up a lot of doors to be in a place of awe and wonder. And so to me, being an awe and wonder is a really awesome part of any given day. So being an awe and wonder to me is, being in awe of the great things that are happening, to sit in gratitude and reflect on the successes that we have and all the different things that we're focused on and talking about. And then in wonder, to be in wonder of, I wonder if, I wonder what is possible. I wonder what could happen, right? And being in awe and wonder, I think all of us honestly should take 10, 15 minutes out of a day to sit and be in awe and wonder. And it is part of a gratitude practice that I participate in. And it's a part of a process that I think, despite major challenges that sit in front of us, it's really easy to get enmeshed in what those are, and not to go, well, most of these problems are actually, I think, solvable, right? What they require is curiosity and going to firsthand to the people who are facing these barriers and really talking to them, which is, I know, what you guys are doing as well. Let me just tell you, in North Carolina, which is where I live, there are several hotspots for colorectal cancer prevalence, particularly in earlier populations. I have given chemotherapy to a 28-year-old with colorectal cancer that was metastatic. And so we have to think very, openly about where these changes are occurring, where barriers to access to care are, and where people are really trying to find where things like routine health maintenance fit into their lives, right? What we understand, for example, is with COVID-19, is that for people in white collar positions, most of them have done quite well, in fact, through the pandemic. But if you're not, there's many threats to your livelihood that exist. There's also several threats related to automation and other things that are just happening in terms of the world economy changing over time. And what I worry about, right, is that as that innovation moves forward, we have to make sure that everyone who's trying to keep up with that can also prioritize healthcare for themselves, that we think about the barriers to that may be logistical and others, and that we take a leadership position, right? As you guys on this call and us at the American Cancer Society and other places take a leadership position to not only solve the challenges of today, but anticipate the challenges of the next 5 years. So with that, I would just love to say, look, I'm thoroughly impressed by what's been shared with me about what's happening here. I really appreciate everyone putting the time aside, because you're all very busy, to get together and talk about these really important topics. And that takes, honestly, it takes commitment, but it also takes bravery, because what you're talking about is not necessarily always easy things, but we know they're worthwhile challenges to solve. And I just want to say that I'm really excited that what you're going to have the rest of this morning is a picture of the impact on health equity and colorectal cancer, where the important challenges are and where we can go, and how we all have to work together, because this is a village type problem. This is not a singular person or entity or organization type problem. And with that, I just want to also say thank you to the sponsors, those who've put forward the time, the resources, the effort, and the people to make this move forward. In particular, the Ohio State University, where I have several close colleagues, and I appreciate the James taking leadership in this. Alongside that, Anthem Blue Cross Blue Shield Foundation, the Harry C. Morse Foundation, the American Electric Power Foundation. Without you, this would not be possible. I also want to say thanks to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions, as you guys think through the important challenges across Ohio and West Virginia. In addition, I'd like to say a special thank you to Dr. Sherry Young for being our AAFP provider liaison for the CME. With that, I'll stop there and say congrats on getting together and the great work that's happening. I hope you learn a lot. And lastly, as the inaugural Chief Patient Officer of the American Cancer Society, I'm here to listen to you. So what's important is I will circle back with Deb and the team and others once you're done today to say, what did we learn in terms of how the American Cancer Society can continue to be helpful in this journey? Because we want to be important and impactful partners in this really important work. So with that, I'll stop and hand it back over to Deb.
Thank you so much, Dr. Kamal. It's a pleasure to have you with us today, and we're so pleased to present this program. Let's go on and we'll review the agenda for this morning. So we'll begin with our health equity and colorectal cancer presentation by Dr. Maria Ubunto. Next, Emily Butler Bell will share tools and resources available to you from the American Cancer Society, supported by colorectal cancer health equity efforts. This will be followed by a short video about the American Cancer Society's Research HERS program. Then we'll be joined by our partners, Dr. Samuel Akinyeye, Dr. Linda Cummings, and Katie Lanham, who are reaching diverse populations. And lastly, you'll hear from Chris Kipp, who is the American Cancer Society Board Chair in Ohio and West Virginia. So that will be our agenda for this morning. And if we can go to the next slide, thank you. The American Academy of Family Physicians has reviewed Ohio-West Virginia Virtual Health Equity in Cancer Forum and deemed it acceptable for up to 2.0 live AAFP prescribed credits. You will receive a certificate to claim your CEs following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. Please note that the planning committee members and speakers have all declared that there are no relative financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please know that slides will be available after today's presentation and that this event is being recorded. Let's take a moment now, and I'll ask our producers to put up our second poll for this morning. We would love to know what sector you represent. So when you see that poll pop up on your screen, please just check the box that reflects your sector that you represent most closely. We'd very much appreciate that. We'll take just a moment, give you time to vote, and just let us know what sector you represent. And what is your relationship to colorectal cancer? And then our producers will take that down and we'll move on. So thank you so much, appreciate that. Let me introduce to you our first speaker of the morning of our panel. Our first speaker is Dr. Maria Ubunto. Dr. Ubunto is a medical doctor with over 20 years of clinical research experience. She received her Doctor of Medicine at the University of the East and served as Family Medicine Medical Director. Dr. Ubunto completed her Master's of Public Health as magna cum laude from the University of Pittsburgh Graduate School of Public Health with certifications in health equity, global health, and evaluation of public health programs. She assumed a position as an epidemiologist at the National Institutes of Health, National Institute on Aging at the Laboratory of Epidemiology and Population Science, conducting colorectal cancer research in collaboration with the National Cancer Institute. Currently, Dr. Ubuntu is a Regional Medical Science Liaison Lead at Exact Sciences. Maria is an advocate for cancer screening and prevention as a member of the Ohio Partners for Cancer Control. Dr. Ubuntu is passionate about serving her community and educating on health promotion and disease prevention. Dr. Ubuntu is recognized for excellence in the medical science lead profession as the recipient of the prestigious Exact Sciences Medical Affairs 2021 Award of Excellence, the Medical Science Liaison Society 2021 MSL of the Year USA, and 2020 MSL Rookie of the Year USA. She is an author of the MSL Journal of the MSL Society and is a national speaker for Physicians Helping Physicians, Women in Bio Pittsburgh, Doctors Crossing Podcast, and the MSL Talk Podcast. We welcome you, Dr. Ubuntu. Thank you for joining us this morning.
Thank you so much, Deb. And also thank you to Dr. Kamal, as well as Leanne here and the American Cancer Society for the invitation during Colorectal Cancer Awareness Month. And a special thank you to my co-presenters, Dr. Samuel Akinyeye and Dr. Linda Cummings. And thank you to all the attendees for the opportunity to educate you on colorectal cancer and screening. My goal today is to share some information with all of you that will hopefully be helpful for you to make informed decisions to improve colorectal cancer screening and adherence for your patients. Next slide, please. So, the previous slide, which is the outline slide. Yeah, so here's what I'll be talking about today. First, I'll discuss the burden of colorectal cancer and screening during the COVID-19 pandemic. Then I'll go over the risk assessment, guidelines, and choice of screening tests. And then my talk discussing a screening option for average risk patients, the multi-target stool DNA or MTS DNA, also known as Cologuard. Next slide, please. So reducing the burden of colorectal cancer. Next slide, please. So here are the pre-COVID-19 estimations of colorectal cancer incidence and mortality in the US. So colorectal cancer remains the second leading cause of cancer mortality. And in 2021 and going into 2022, there's an estimated 150,000 new cases of colorectal cancer diagnosed in the US. And the American Cancer Society estimates that about 53,000 patients will die from colorectal cancer. The overall lifetime risk of developing colorectal cancer from birth to death for men is 4.3%, and for women is 4%. Next slide, please. The risk of colorectal cancer increases with age and is most commonly diagnosed in people over the age of 50, as shown in the table. Now, colorectal cancer trends overall reflect the majority of cases that occur in older age groups, masking the trends in young adults. The incidence and mortality is on the rise in younger populations and have been increasing since the mid-1980s in adults ages 20 to 39 years, and since the mid-1990s in adults ages 40 to 50 years, with younger age groups experiencing the steepest increase. So this pattern is called a birth cohort effect, because generations of individuals with higher incidence carry the elevated risk with them as they age. And the graph on the right shows a steep increase in adenocarcinoma incidence rate in the 49 to 50 age group from 46.1% to 51%. Next slide, please. So significant disparities in colorectal cancer screening, incidence, and mortality persist by race or ethnicity and gender. And among the broadly defined racial and ethnic groups, colorectal cancer incidence and mortality are highest in non-Hispanic Blacks, followed closely by American Indians and Alaska Natives, and lowest in Asian or Pacific Islanders. So during 2012 to 2016, colorectal cancer incidence rates in Blacks were about 20% higher than those in non-Hispanic whites and 50% higher than those in the Asian or Pacific Islanders. And the disparity for mortality is twice that for incidence. So colorectal cancer death rates in Blacks are almost 40% higher than those in non-Hispanic whites and double those in Asians. And the reasons for racial or ethnic disparities in colorectal cancer are complex, but largely reflect differences in risk factors, prevalence, and also healthcare access, both of which are related to socioeconomic status. Next slide, please. So if there's one thing about this presentation that I would like for you to remember is that colorectal cancer is one of the most preventable and treatable forms of cancer, and catching it early improves survival. So this is a picture showing polyps or adenomas growing in the large intestine at different stages. About 70% of colorectal cancers develop from benign adenomas, and it typically takes more than 10 years to develop, which provides that important window of opportunity to catch the disease early. So we know that early detection of colorectal cancer is associated with improved survival rates. 9 out of 10 patients diagnosed in the early stages have a 5-year survival rate, compared to 1 out of 10 patients diagnosed in stage 4 or advanced disease. Next slide, please. So shown here is a graph of the colorectal cancer screening rates in the US from 2005 to 2018. And as you can see, although the screening rates are gradually increasing, the rates are lower than that for mammograms for breast cancer and Pap tests for cervical cancers. And the overall colorectal cancer screening rate as of 2018 was at 67%, which falls short of that national goal of 80% compliance in every community. And the screening rates are still low. As of 2016, about 1 in 3 people aged 50 to 75 were not up to date with their screening, and 25% have never been screened for colorectal cancer. So there is room for improvement, and we all have a role to play. Next slide, please. So colorectal cancer rates in any state have not reached the national goal of 80%. And this is a nice map from the colorectal cancer facts and figures showing how your state compares to the rest of the country. And as you can see, as of 2018, the screening rate for the states of Ohio and West Virginia is at 67% of adults aged 50 to 75 who report being up to date. And the percentage has gone up by 1 percentage point at 68% as of 2020 to 2022 report, whereas Pennsylvania has gone down to 70%. So again, there is room for improvement. Next slide, please. So next, I'll discuss the impact of COVID-19 on cancer screening. So at the onset of the COVID-19 pandemic, elective medical procedures, including cancer screening, were largely put on hold to prioritize urgent needs and reduce the risk of the spread of COVID-19 in healthcare settings. And one consequence of this has been a substantial decline in cancer screening. And based on data from 2020, diagnostics used to screen and monitor cancer have dropped dramatically due to postponement of non-essential visits and diagnostic testing procedures such as colonoscopies and CT scans. And across the board, there was a sharp decrease in breast, colorectal cancer, and cervical cancer screenings. And there was an 85 to 90% decrease in screenings for colorectal cancer and an 87 to 94% decrease in mammograms for breast cancer screening. Next slide, please. So here's results from a retrospective cohort study of COVID and Cancer Research Network data comparing patient encounter. The data is from January to April 2019 versus the same month in 2020. And it's of a network of 20 institutions across the US with over 28 million patients. And the graph on the right shows April displayed the greatest drop, where screening of patients with colorectal cancer fell by 84.5% when comparing 2022 with 2019. Next slide, please. Preventive cancer screenings during COVID-19 pandemic have decreased dramatically from data pooled from 60 healthcare organizations representing 306 hospitals that span 28 states and cover 9.8 million patients. And colorectal cancer in particular had a 64% reduction with an estimated 95,000 missed screens from March to June last year. So delayed or missed screening could cause some cancer to be diagnosed at a later stage with a poor prognosis. Next slide, please. When compared to colorectal cancer screening in prior years, colorectal cancer screening among health plan enrollees had a 3.8 million total estimated colorectal cancer screening deficit for the US population from January to July 2020. Next slide, please. So last year during shelter in place, there were reductions in outpatient visits and colorectal cancer screening modalities such as colonoscopy and home-based stool test. However, the MTS DNA testing was less effective than FIT or colonoscopy. Then after the clinic reopenings took place, colonoscopy screenings only increased slightly, and neither MTS DNA screening nor FIT increased. And family medicine outpatient visits increased to approximately 80%, and conversely, in-person visits decreased by 88%. And however, telemedicine and video conferencing have continued to increase. Next slide, please. So it's no surprise that the impact of the pandemic on future cancer outcomes has resulted in reduced access to care, unemployment, delayed routine care, later stage diagnosis, and delayed treatment. And this has implications in underserved communities and marginalized populations. Next slide, please. Next slide. So now I'll discuss the risk assessment guidelines and choice. So the term average risk is used instead of low risk because anybody with a colon has a risk of colon cancer. And the concept of average risk versus high risk is key to making decisions about colorectal cancer screening. And there's no uniform definition of average risk in scientific literature. And however, a patient is considered to be in the average risk category if he or she is not in the high risk category or doesn't have any known risk factors for colorectal cancer other than their age. Asymptomatic patients are generally considered to be at the average risk for colorectal cancer if they do not have the following: a personal or family history of colorectal cancer, adenomas or other related cancers, or if they've been diagnosed with inflammatory bowel diseases such as ulcerative colitis or Crohn's disease. They're also not average risk if they have a first-degree relative with any of the hereditary cancer syndromes, such as familial adenomatous polyposis or hereditary non-polyposis colorectal cancer syndrome, also known as Lynch syndrome. And certain factors associated with Western lifestyle and diet may increase the risk of developing colorectal cancer, such as cigarette smoking, diabetes, obesity, etc. But it's important to note that these risk factors alone do not elevate a person's risk beyond the average risk category. Next slide, please. Can you hear me okay? I think there was a glitch.
We can hear you fine, Dr. Ubuntu.
Yeah, I don't see the next slide on my end.
We're looking at summary of current guideline recommendations.
Okay, all right, sorry. So here is the summary of current guideline recommendations for colorectal cancer screening for persons at average risk. And there are 4 major organizations that recommend the guidelines for colorectal cancer screening. And they are the USPSTF, the American Cancer Society, the National Comprehensive Cancer Network, the Multi-Society Task Force, which comprises 3 of different GI societies, which is ACG, ASGE, and AGA. In May of 2018, the American Cancer Society revised its colorectal cancer screening guidelines to include patients 45 years or older who are at average risk for colorectal cancer. And then in 2021, organizations like the USPSTF followed suit and updated their guidelines. And then despite some variations in their respective guidelines, the organizations recommend routine colorectal cancer screening for patients with average risk between the ages of 45 and 75 years. Most major guidelines have lowered the screening age to 45, given the recent increase of CRC in people under the age of 50. And guidelines suggest that whether to screen patients 75 years or older should be an individualized decision based on such factors as patient health, comorbidities, life expectancy, previous colorectal cancer screening history, and patient preferences. So next slide, please. So as I mentioned, most major professional organizations recommended screening for colorectal cancer screening in average risk adults starting at age 45, in addition to recommendation to screen eligible adults greater than 50 years. So their recommendations come with additional considerations as there's lack of empirical data to support screening at an earlier age. Recommendations from the American Cancer Society, for example, base earlier age of screening on modeling estimations and recent SEER data observations and increased incidence in younger populations. Next slide, please. So as for the USPSTF, they gave a grade A recommendation to screen all adults ages 50 to 75 years old and a grade B recommendation to screen 45 to 49-year-olds. And they concluded with high certainty that there is a moderate net benefit of starting screening for colorectal cancer in adults aged 45 to 49. Next slide, please. So this is one of the most important slides that highlight the guideline recommendations and choice of test. Major organizations listed in the table recommend screening methods that can help detect colorectal cancer early when it's most treatable. So average risk individuals can be screened by non-invasive stool tests or directly by visual examinations. So stool tests are recommended annually, such as FIT, high sensitivity FOBT, or MTS DNA. However, the multi-target stool DNA test is recommended every 1 to 3 years and has been shown to be most beneficial every 3 years, starting at the age of 45 for average risk individuals. Colonoscopy is recommended at 10-year intervals, while CT colonography and FLEX-SIG are recommended every 5 years. And FLEX-SIG can be extended to every 10 years if it's used in combination with annual FIT. And it's important that when patients receive a positive stool test result, that they are followed up with a timely colonoscopy. Next slide, please. So identifying barriers to colorectal cancer screening that contribute to low adherence is one way we can target communication strategy to improve compliance. And this survey was conducted at 130 ACOs showing PCP barriers to colorectal cancer screening were mostly at the patient level. So 70% of providers thought that a patient's greatest barrier was fear of discomfort or pain, followed by at least 62% of physicians reporting finances as patient barriers. And clinicians perceived their own barriers were lack of time to discuss screening, lack of provider recommendations, and questions about screening efficacy. Now, at the system level, the barriers were lack of a reminder system, lack of support staff, and shortage of screening facilities. The takeaway from the survey is the need to address colorectal cancer screening barriers on multiple levels, the patient, provider, and system level. Next slide, please. This is one study from 11 safety net primary care sites where about 200 previously screened and unscreened patients were surveyed on what barriers got in the way of being screened. So participants reported fear related to colorectal cancer screening and expressed concerns related to the procedure, sedation, and outcomes of the procedure. And other barriers included medical mistrust, lack of information on colorectal cancer screening, religious reasons, or that they simply don't want to. Next slide, please. When we look at colorectal cancer screening by subpopulations in adults 50 years and older, colorectal cancer screening rates are much lower than the national average in certain subpopulations aged 50 to 75. So adults aged 50 to 64 were less likely to have been screened than those 65 or older. Screening prevalence among whites and Blacks was higher than among Asians, American Indians, and Alaska Natives and Hispanics. Screening was lowest among the uninsured and immigrants who had resided in the US for fewer than 10 years. And barriers to screening include inadequate insurance coverage, lack of provider recommendation, logistic factors such as transportation, language barriers, fear, and lack of knowledge. Now, these barriers are more prevalent among people with fewer financial resources, lower educational attainment, and among racial or ethnic minorities, resulting in disparities in screening prevalence and outcome. And interventions to help overcome these barriers include increasing individual patient awareness, such as education and reminders, and ease of access, as well as shared decision-making. So it's a multi-component intervention that's recommended because there are more effective at increase in colorectal cancer screening utilization than a single approach. The next slide, please. It's kind of hanging again. Let me see. Okay, so most screening in the US is opportunistic rather than programmatic, where primary care providers play a role in the uptake of colorectal cancer screening. So it's an office-based interaction between healthcare provider and patient. And the programmatic or system-wide approach is an organized approach to offering screening to a population or members of a healthcare plan. Next slide, please. So how can we improve patient adherence? Well, one way is informed decision-making, which is an approach to address barriers to screening and is recommended by national guidelines to improve screening adherence. So an example is when a healthcare provider offers a patient colorectal cancer screening options, describes the risks and benefits, and the patient weighs in and expresses his or her preferences and values. And this gives patients more control over their own health. And you may consider a variety of factors in deciding which test may be best for each person. So because there are multiple options for screening, the choice of a particular screening modality should include a conversation with the patient and concerning the preferences and resource availability. Because studies have shown that offering patients a choice of screening method may improve colorectal cancer screening rates. And in some instances, the best screening test can be considered the one that is acceptable by the patient and gets completed. Next slide, please. So there are a few randomized controlled trials on this topic, and here's one RCT that showed patient compliance with colorectal cancer screening increased by 31% when patients were given a choice of tests compared with only offering colonoscopy. And offering a choice of screening method may be linked to greater screening adherence. And then cultural influence also play a role in colorectal cancer screening adherence. For example, African Americans, Asians, and Latino patients, they prefer the non-invasive fecal testing, whereas white patients prefer colonoscopy. Next slide, please. So now I'm going to pivot. In the next two slides, I'll be reading the indications and contraindications, warning and precautions of MTS DNA or Cologuard, and that's on our label, and this is for compliance purposes. So Cologuard is intended for the qualitative detection of colorectal neoplasia, associated DNA markers, and for the presence of occult hemoglobin in human stool. A positive result may indicate the presence of colorectal cancer or advanced adenoma and should be followed by a diagnostic colonoscopy. So Cologuard is indicated to screen adults of either sex 45 years or older who are at typical average risk of colorectal cancer. Cologuard is not a replacement for diagnostic colonoscopy or surveillance colonoscopy in high-risk individuals. As for contraindications, Cologuard is intended for use with patients aged 45 years and older at average risk and who are typical candidates for colorectal cancer screening. Cologuard was not clinically evaluated for the following types of patients: patients with a history of colorectal cancer, adenomas, or other related cancers, patients who've had a positive result from another colorectal cancer screening method within the last 6 months, and patients who've been diagnosed with a condition that is associated with high risk for colorectal cancer, including but not limited to inflammatory bowel disease, chronic ulcerative colitis or Crohn's disease, familial adenomatous polyposis, or a family history of colorectal cancer. And patients who have been diagnosed with a relevant familial hereditary cancer syndrome, such as Lynch syndrome. Next slide, please. So the performance of Cologuard has been established in a cross-sectional single point in time study. The programmatic performance of Cologuard, which includes benefits and risks with repeated testing over an established period of time, has not been studied. And performance also has not been evaluated in adults who have been previously tested with Cologuard. Non-inferiority or superiority of Cologuard programmatic sensitivity as compared to other recommended screening methods for colorectal cancer and advanced adenomas has not been established. The clinical validation studies were conducted in patients over 50 years of age. The American Cancer Society guidelines recommend that screening begin at age 45, and Cologuard performance in patients ages 45 to 49 years was estimated by subgroup analysis of near age groups. Colorectal cancer screening guideline recommendations vary for persons over the age of 75. And the decision to screen persons over the age of 75 should be made on an individualized basis in consultation with a healthcare provider. Cologuard test results should be interpreted with caution in older patients as the rate of false positive results increases with age. A negative Cologuard test result does not guarantee the absence of cancer or advanced adenoma. Patients with a negative Cologuard test result should be advised to continue participating in a colorectal cancer screening program with another recommended screening method. And the screening interval for this follow-up has not been established. Cologuard may produce false negative or false positive results. A false positive result occurs when Cologuard produces a positive result, even though colonoscopy will not find cancer or precancerous polyps. A false negative result occurs when Cologuard does not detect a precancerous polyp or colorectal cancer, even when a colonoscopy identifies a positive result. And patients should not provide a Cologuard if they have diarrhea or if they have blood in their urine or stool that could be from bleeding hemorrhoids, bleeding cuts or wounds on their hand, rectal bleeding, or menstruation. And to ensure the integrity of the sample, the lab must receive the patient's specimens within 72 hours of collection. And patients should send stool samples to the lab according to instructions in the Cologuard patient guide. And patients should be advised of the caution listed in the Cologuard patient guide. Patients should not drink the preservative liquid, and the risks related to using the Cologuard kit are low, with no serious adverse events reported among people in a clinical trial. And patients should be careful when opening and closing the lids to avoid the risk of hand strain. Next slide, please. Next slide, please. So what is MTS DNA? So it is a simple to use, sensitive, non-invasive colorectal cancer screening test. It identifies 11 biomarkers in stool that are associated with colorectal cancer and advanced adenomas with a 92% sensitivity. And it's indicated for average risk adults age 45 years and older. And what's also unique about the test is the embedded nationwide patient navigation and customer service to support patients to complete the test. Next slide, please. Thank you. So this is a picture of a cross-section showing polyps or adenomas growing in the large intestine. And colorectal cancer usually begins as a polyp and may progress to cancer. And the lesions start locally within the wall of the colon and rectum. And as bowel lesions grow and develop, they continue to shed DNA biomarkers and blood into the stool. And Cologuard is uniquely designed to detect 10 DNA biomarkers plus a hemoglobin marker, which are isolated in the stool sample for further testing. Next slide, please. So the test itself is a combination of a panel of biomarkers and an algorithm to maximize sensitivity. The MTS DNA test analyzes a patient's stool for 11 molecular markers, which are 2 DNA methylation markers, NDRG4 and BMP3, 7 DNA mutation markers, all KRAS, 1 DNA normalization marker, beta-actin, and 1 fecal hemoglobin marker. Then the DNA test and the hemoglobin test are analyzed in parallel, and based on a combined result, a mathematical algorithm determines a qualitative negative or positive result. And a negative result means that the MTS DNA test did not detect abnormal DNA and or hemoglobin biomarkers in the stool, which are associated with colorectal cancer or advanced adenomas. And a positive result does not necessarily mean that a patient has cancer. It means that MTS DNA test detected elevated levels of DNA and or hemoglobin biomarkers in the stool, which are associated with colorectal cancer or advanced adenoma. Next slide, please. When you, the healthcare provider, orders the MTS DNA test, Exact Sciences lab will ship the kit directly to the patient and contact the patients with instructions for collecting and returning the test. The patient navigation support service that includes a welcome call, email, text reminders, 24/7 customer support in over 200 languages. And then the patient completes the test and ships the kit back to Exact Sciences lab for processing. And then the lab processes and analyzes the patient's MTS DNA test and typically provides results to the provider in about 2 weeks. And then the provider reviews the result, performs the appropriate patient follow-up. And if it's a positive result, then your patient should be referred for a follow-up colonoscopy. And if the result is negative, then the patient can continue with screening and risk assessment as appropriate intervals, which is every 3 years. Next slide, please. So you might be asking yourself, is MTS DNA appropriate for your patients? Next slide, please. So if your patient is 45 years or older, and if they have any of the risk factors, such as personal or family history of colorectal cancer, IBD, or any of the hereditary cancer syndromes, or if they've had a positive test result within the last 6 months, or signs and symptoms that may indicate colorectal cancer, such as blood in the stools, they are not eligible for MTS DNA or Cologuard. And remember that other factors associated with increased colorectal cancer risk, such as obesity, they should be taken into account as part of the clinical judgment. And then the decision to screen those over the age of 75 should be an individualized one, as DNA methylation and false positive rate increases with age. Next slide, please. So MTS DNA is included in the following major quality measures, and making it part of that standard of care for colorectal cancer screening. The National Committee for Quality Assurance includes MTS DNA within its HEDIS quality measures with every 3 years of credit. Next slide, please. So in summary, colorectal cancer is the second most common cause of cancer-related mortality in the US, but it can be prevented with early detection, because 1 in 3 adults aged 50 to 75 were either not up to date with screening recommendations or have never been screened. And so providing patients with a colorectal cancer screening option can help improve screening adherence. And then we need a multi-component intervention, because they are more effective at increasing colorectal cancer screening utilization than a single approach. And then the MTS DNA test is a highly sensitive stool-based screening test option that primary care providers may consider for their patients aged 45 years and older who are at average risk for colorectal cancer. And then lastly, Exact Sciences Medical Affairs recently created this Exact Academy. It's an educational platform where you can learn about colorectal cancer and screening and the science of the multi-target stool DNA test or Cologuard. And you can use the link or scan the QR code, and we'd be very interested in hearing your feedback, insights, and also the site content and your learning experience. Next slide, please. And with that, I'd like to thank you for your time and attention.
Dr. Ubuntu, thank you so much. We do appreciate your comments this morning very much. And the slides will be available after today's webinar. And if you do have questions, please pop them in the chat or pop them in the Q&A. All right, let's move on to our next speaker. Emily Butler Bell will be joining us next. Emily is the director for the National Colorectal Cancer Roundtable and Colorectal Cancer Interventions at the American Cancer Society. Welcome, Emily. We're glad you're with us this morning.
Great, thank you so much. So good morning, everyone. I want to share a thank you to our hosts and to everyone participating today. I always learn so much from state level efforts to increase colorectal cancer screening, so it's a real treat for me to be invited to participate in this session. So today I'll be sharing with you a bit about some of the resources available to you in your efforts to increase colorectal cancer screening, all of which were developed with the lens of health equity to ensure we're supporting local communities and addressing the persistent and unacceptable disparities that we see in both colorectal cancer screening and outcomes. But before we get started, I'd like to share a bit of background about the National Colorectal Cancer Roundtable and our 80% in Every Community campaign. Hopefully many of you are familiar already, so this will be just a quick refresher, but want to be sure to introduce those of you that might be new to our work. So the NCCRT is a national coalition of public, private, and voluntary organizations, all dedicated to reducing the incidence and mortality from colorectal cancer in the United States. And we're essentially an organization of organizations, all sharing the ultimate goal to increase the use of those proven colorectal cancer screening tests among everyone who should be screened. Next slide. We were co-founded by the American Cancer Society and the CDC back in 1997. We just celebrated our 25th birthday. And today the NCCRT includes over 150 member organizations. These include medical professional societies, major cancer centers, nonprofit organizations, federal agencies, state departments of health, state cancer coalitions, health plans, numerous partners, as well as several corporate associates, including Exact Sciences. The member representatives from those organizations include nationally known experts, thought leaders, and decision makers. And they come together throughout the year to participate in strategic priority teams and special topic meetings. And then each year, our 80% Every Community Conference and NCCRT annual meeting addresses important topics and sets the agenda for the following year. It's typically middle of November, and we're really close to setting the date. So part of the meeting is members only, but we've opened up a track for anyone to participate in that's interested. So keep an eye out for that date coming soon. Next slide. And so while the NCCRT has been working to advance screening for over 25 years now, our work really kicked into high gear with the launch of our first campaign to reach an 80% screening rate back in 2014. It was called 80% by 2018. Of course, we had a branding problem as we approached 2018. So we worked with our members and partners to understand, what was important to them about that campaign and what did they want to see going forward. So we developed our current campaign, which is called 80% in Every Community. It includes that same target to try to reach an 80% screening rate, but the focus is even more so on supporting local communities with tools and resources to address colorectal cancer screening and outcome disparities. And while screening rates are rising at an exciting pace, except for some blips that we're seeing with COVID, we know that not everyone is benefiting equally. There's still many communities with lower colorectal cancer screening rates, including certain racial and ethnic communities, lower income communities, and others. And so our commitment with 80% in Every Community is to continue our work to bring down barriers and address screening inequities so that everyone can live a life free of colorectal cancer. Next slide. Here we had hoped to share a video. We had some issues with it, but we'll be sending around the link so that everybody can see. It's really just a 2-minute snapshot of our work in our campaign and how it relates to addressing health equity. I believe there was one slide before this one.
Because of how community is defined, and that is defined very broadly.
We really have to focus on not only those communities that are doing well, that just need a couple of percent to get to 80%, but really we have to focus on those who are 60%, 50% and below to make sure that we raise them up. And that may require that we have targeted interventions or programs just for that population to do so.
I'm motivated to be a part of 80% in Every Community because I think it really drives home to me that I have a role to play. And it doesn't have to be in my occupation. It doesn't have to be as a part of a large organization. I can get my family screened. I can get my friends screened. I can touch the lives of individuals who I hope will prevent cancer and avoid a story that can be devastating.
For me, the campaign about 80% in every community is about involving everybody and really saying, okay, if we're all together pushing towards a similar goal, no matter what we do, we're all pushing in the same direction, then the larger impact will be a national impact.
The African proverb says, if you want to go fast, go alone. If you want to go far, go together. When I think about the work of NCCRT, we're going to go very far, and that's because of our togetherness. It's because of our connectedness.
I feel so confident, so sure that this group will get it done.
Great. Well, I'm so glad we were able to see some of that. The beginning was cut off, and it was, of course, too small to see titles, but it's on our website, and we'll send around the link. Those were a few of our incredible past and current steering committee members. So here I wanted to provide a snapshot of some of the ways in which the state of Ohio is participating. And I neglected to include West Virginia, which I feel terrible about, but wanted to point out too that we have incredible partners in West Virginia. So for Ohio, we have the Ohio State Comprehensive Cancer Center as an active member. We have 53 organizations which have pledged a commitment to working towards 80% in every community. They are part of the over 1,800 organizations which have made that commitment. And then we've had a couple different Ohio organizations that have received one of our 80% in every community National Achievement Awards back in 2018. So the Ohio Academy of Family Physicians, and then the it's a long title, but the Ohio State University Cancer Center, which has done some incredible work. And then from West Virginia, we actually have 75 pledgees, incredible commitment coming from our West Virginia partners. And the West Virginia Mountains of Hope Cancer Coalition has been a long time and really engaged member. So thank you so much for your partnership. It really is the boots on the ground effort of our local partners that are driving change in our communities. So to provide you with just a quick snapshot of some of the resources available to you, next slide. I want to first point you to the NCCRT Resource Center. This is really a goldmine on our website. You can search by setting, population of focus, and other keyword search terms to find tools and resources to support you in your work. There's dozens of tools, both developed by the NCCRT, but it also includes vetted tools that have been submitted by our members and partners. And there's an option to submit a tool for consideration, and encourage you to do so. So today I'll just share with you a snapshot, but I encourage you to bookmark the website and visit often. Next slide. So first, I wanted to point out that we have a number of briefs for key partners to help support in the 80% in every community effort. And looking at this list, I think what really resonates is that everyone has a role to play in increasing colorectal cancer screening. You know, I think 25 years ago, we started our work working with primary care and GIs, some of the state level cancer coalitions, but that's grown over the years. So with the launch of our 80% campaigns, we have more and more employers that are interested in working with us. We have elected official champions. We have women's health providers that want to be a part of this work and are part of our membership. So definitely encourage you to take a look at our website and use these briefs to get some of the new partners interested and share with them how they can be a part of this national effort. Next slide. And then probably our signature resource that is our most downloaded tool is our NCCRT STEPS guide for increasing colorectal cancer screening rates in community health centers. It provides step-by-step instructions for health centers to implement the processes needed to increase screening. It provides guidance on conducting baseline screening rates, assessing capacity, and preparing your team. It also provides field-tested tools, templates, and resources to help you get started. And I'm thrilled to share with you that the tool is undergoing a major update over the last several months. We have an advisory group of experts from across the nation supporting the work, and includes numerous updates. So first and most importantly, it's expanding the scope to include, to be relevant to both community health centers and to general primary care practices. It now includes the age 45 starting age. It includes updates from the latest science and best practices. Next slide. And then it also includes 10 case studies that outline best practices and lessons learned to really give you a look at what's happening in local areas across the country. So one of them, just to give you a flavor for this work, is Noella Community Health Center based out of New Orleans. They have patients that the majority of which prefer to speak in a language other than English. About a quarter uninsured. Their primary strategy was screening navigation, and they reached screening rates of 80% in 2018. They've had some trouble sustaining that with impacts from COVID, but just really incredible work. And this is just one of many examples that you'll find in this tool. So the original tool is available on our website now, and the new tool, we're looking at the first week of May to launch that, and we'll be sharing a deep dive into it in a webinar as well, and we'll be sure to get that information to you. Next slide. And others of our most popular tools include our suite of messaging materials. So we've done a series of market research deep dives to really understand who are the unscreened, who are the screened, what are their barriers, what motivates them to take action, what channels are the best ways to reach them, and then what are the messages that resonate with them and that they share will help get them screened. So our 2019 messaging guidebook is our latest look at a general population. It includes profiles for priority populations and tested messages for reaching them. We've seen huge successes with health plans, state coalitions, and other partners using these tools and applying them in their communities. Next slide. And then we also have a couple companion guides that expand on this work. So we created a companion guide for reaching Hispanics and Latinos, one for reaching Asian Americans, and we're also right now conducting market research to provide new guidance on reaching Black and African American adults, as well as some market research on reaching early messaging to reach either the soon-to-be eligible or the newly eligible, to really ensure that we're reaching that age 45 population or younger if screening is appropriate at a younger age. These should be coming later this spring or early summer. Next slide. Another implementation toolkit that has been a signature resource for us is our hospital handbook. It provides best practices on the design and delivery of screening within the hospital and health system setting. And it also includes 12 case studies, best practices, lessons learned, and then templates and tools to help you get started. Next slide. And of those case studies, it does include one from Ohio. So Southwest General Health Center, which is a community hospital serving the Cleveland metro area. The hospital began targeting screening efforts with their employees and then expanded its efforts to serve the broader community. They saw an increase in screening of 5 percentage points just in 1 year. So phenomenal work. I definitely encourage you to take a look in the handbook and learn more about what they've done. Another tool that I wanted to point you to, especially given the increasing rates of early age onset colorectal cancer, is our risk assessment and screening toolkit. So this provides guidance on using family history information in the primary care practice environment. It's a risk assessment tool and screening guide, and it's intended to assist primary care clinicians and their staff in collecting and acting on risk factor information. So the important thing to do is to begin screening promptly at the age at which screening is recommended, whether that be age 45 or earlier. And this tool is intended to support practices in making sure that they do that. Next slide. One of the signature pieces of this guide is 2 screening algorithms, which outline recommended screening options for the average risk and high risk patients. It's a great sample starter policy for primary care practices, and we have it both in age 45 and in age 50 for those that haven't yet implemented the age 45 starting age. Next slide. And then another one of our most highly used tools is our clinician's reference on stool-based tests for colorectal cancer screening. It highlights the value of stool-based tests for colorectal cancer and includes information on sensitivity and specificity for many of the common tests. This has been really popular for partners that are approaching healthcare systems that maybe still be looking at colonoscopy as a gold standard, and this tool is meant to really share that evidence and best practices to help them understand how stool-based testing can be a great complement and to share the full menu of options for screening for patients for which it's appropriate. And then in terms of how to get involved, I definitely encourage you to visit our website. You can follow us on social media, on Twitter at NCCRT News, and use the hashtag #InEveryCommunity, especially if you have a success to share. We love to see those use of the hashtag, and then we'll go amplify your message. You can sign up for our newsletter on our website under the Get Involved tab. You can take the 80% pledge if your organization hasn't already done so. There's no teeth to the pledge. It's really just a sharing a commitment to work towards that 80% goal and be a part of the national effort. And then if you think it might be a good fit to really sustain your engagement, definitely would love to see more organizations apply for NCCRT membership. And there's links to the membership application and responsibilities and criteria on our website. So that's it for me, but I really, again, appreciate you sharing your time with me and look forward to your questions either at the end of the session, or please feel free to reach out to us through our NCCRT email address too. So thank you.
Emily, thank you so much. We do appreciate you being with us this morning and sharing the tools and resources. We appreciate it. If anyone has questions, please feel free to pop them in the Q&A or in the chat, and I'm sure that our presenters will be keeping an eye on that. Next, we're going to put a poll question up before I introduce our next speaker. We would just like to know, what do you observe as the biggest barriers when it comes to colorectal cancer screening? You're welcome to choose all that apply. We welcome you to make your selections, and we'll give you just a moment to do that before I introduce our next speaker. So take just a moment, make your selections if you will. We'll give you a moment to think about it. And once you've made your selections, I'm going to go ahead and start making an introduction here. Our next speaker is Dr. Samuel Akinyeye. Dr. Akinyeye was born in Lagos, Nigeria, and raised mainly in Houston, Texas. He attended the University of Texas at Austin, where he earned a bachelor's degree in neurobiology. He then earned his medical degree and completed his residency in internal medicine at Baylor College of Medicine in Houston. Dr. Akinyeye is finishing his gastroenterology fellowship training at the Ohio State University Wexner Medical Center. His focus is on general gastroenterology with an interest in health equity and mentorship recruitment of underrepresented minorities in medicine. Welcome, Dr. Akinyeye. Thank you for being with us this morning.
Thank you. Thank you, Deb. Thank you, American Cancer Society, everybody for putting this on, fellow speakers, and thank you all that are in attendance today. I'm going to be speaking about colorectal cancer and just kind of a look through a health equity lens, specifically focusing on African Americans. And so today we're just going to be speaking on, I'm going to go over some health equity terminology, colorectal statistics, trends, barriers to screening, specifically in the African American population, solutions to combat these barriers, not a whole list, but some, and then initiatives at The Ohio State, which we are doing. Some of these topics and themes have already kind of been presented before, but I think it's great to kind of just reemphasize and hammer in some of these very important topics. And so a couple of terminology that I want to go over: health equity. And so this is where everyone in society has the same opportunity to achieve and sustain optimal health. Health disparities, these are measurable differences in the incidence and prevalence of health conditions, health status, and outcomes between groups. And then there's health inequities, and these are when health disparities are the result of unfair social, economic, political, and environmental factors that are systematic and systemic in nature. Go to the next slide. And so I love this graphic, just really differentiating between equality and equity. And so we have, for equality here at the top, we have 4 different people, and we essentially have given them the same bike or the same resource, and we expect them to be successful. And that's not always the case. And so on the bottom here, we have equity, and where we have those same 4 different people, and we've taken into account their background, the way they've been raised. And so we tailor the resources towards the individual. And so that's kind of difference between equity and equality, is really taking the individual or the group into consideration. Go to the next slide, please. And so this is a graph that I actually took from the American Cancer Society website, discussing the incidence and mortality of colorectal cancer amongst different racial groups. And so we have non-Hispanic, Black, American Indian, Alaska Native, non-Hispanic, white, Hispanic, and Asia Pacific Islander. And so as you see here, we also differentiate them by gender. And you see here males, higher incidence, higher mortality of colorectal cancer. And then amongst the different groups, highest in non-Hispanic Black at 45.7%, lowest in Asian Pacific Islander at 30%. And so we also see that the mortality is also increased again in non-Hispanic Black, lowest in Asian Pacific Islander. The one thing I'll note, and something that always kind of catches me, is when we differentiate between Alaskan Native and American Indian, you can see actually the Alaskan Native population is almost double incidence mortality of non-Hispanic Black. So that's a group that's also very high rates of disparities when it comes to colorectal cancer incidence and mortality, for very similar reasons as kind of non-Hispanic Black and other groups. You can go to the next slide. And so this is the grim reality for a lot of for African Americans as a group, is higher incidence of developing colorectal cancer. As Dr. Ubunto mentioned earlier, there's 20% higher rates of developing colorectal cancer compared to other groups, more likely to develop this at a younger age, diagnosed further in the illness, and then more likely to die of the disease. 40% higher mortality than other groups. You know, and then also less likely to receive chemo and then surgery. When I think of this too, I think of Chadwick, but we know in pop culture, Chadwick Boseman, Black Panther, and then Natalie Desselle-Reid. These are people that we knew that, you know, Chadwick passed in his 40s and Natalie passed in her 50s from colorectal cancer. And so very sad. Go to the next slide. And so this is a graph and the table that I looking at kind of colorectal cancer screening and modalities before and after the Affordable Care Act. And so we know the Affordable Care Act kind of came into about 2010. And so if you see here on the left, we have different racial groups, and we have the colorectal screening rates among those groups over a span from 2008 to 2016. And so as you see here, as people have mentioned before, the colorectal cancer screening rates have increased over time in general amongst all groups included. And you see here non-Hispanic white, Hispanic, non-Hispanic Asian, and you see generally an increased trend. The one thing I'll highlight is if you look at the upper right in non-Hispanic Black, we did see a trend increasing up until about 2014, and it's kind of slightly decreased or plateaued. And so that's something, again, focusing our efforts kind of in this group to kind of see what's going on, trying to increase those rates. On the right side here, we have a table looking at different screening modalities over time. And as you see with colonoscopy, started 74% back in 2008. And after the Affordable Care Act has increased up until 83%. The one thing I'll note is if you look at FIT and FOBT testing, it was 7.5 in 2008, and now it's 6.1%. So a slight decrease, which is interesting to know because we have several studies that have not come out to date showing that mailed FIT testing can be an effective way of increasing colorectal cancer screening, especially in underserved or low resource populations. Okay, we can go to next slide. And so as I kind of transition into talking about these barriers as well as potential solutions, I just want us to keep in mind too that there are barriers that we perceive towards colorectal cancer screening, and then there are barriers that the patient perceives. So we can go to the next slide. Oh, sorry, I guess it'll probably need to fill all the way through. But so these are barriers to screening, and essentially they're multifactorial, and just showcasing again that they start at patient level, there's provider level, health system level, and then there's national policy level. And so I wanted to just briefly go over some of these. And so we have here at the patient level, there's the fear. There's the fear potentially of the procedure, but then there's also the fear of the diagnosis. I remember taking care of a patient my first year in fellowship, and she had some bleeding. We did a colonoscopy, and we ended up finding colon cancer. And I remember discussing later on with her, we got on the subject of why she hadn't gotten a colonoscopy earlier. And she had told me she was just fearful that she might have colorectal cancer or what it might show. And it just kind of broke my heart, because potentially if we had reached her earlier, maybe we could have prevented this. There's distrust. We're all aware of Tuskegee, Henrietta Lacks, and a lot of these terrible events that have happened in our country's history that have led to distrust that has persisted for years in towards people of color. And so we have to keep these things in mind as we're kind of presenting options for colorectal cancer screening. There's beliefs, and so there's studies that have shown that there are some people in African American community that don't believe that there's a cause for colorectal cancer, and there's no way to prevent it. And so unfortunately, we know that not to be the case, and we need to make sure that we're kind of providing the right education at the right level to reach these people. There's comorbidities and other priorities. That we have patients that they have heart failure, diabetes, they have all these different things, and on top of it, we're asking them to now get screened for colon cancer, and sometimes it can just be too much. And so those can sometimes be some barriers at that patient level. At the provider level, there's lack of recommendation and knowledge. I feel those go hand in hand. And so sometimes, the provider doesn't necessarily know, what is a high-risk patient? When am I supposed to be screening for colon cancer? And so, we need to make sure that we're kind of staying educated with the guidelines and things like that. As GI providers, we need to, when we sign our colonoscopy report, make sure that we're putting the appropriate follow-up screening intervals as well. Bias and discrimination. And so this is kind of the implicit bias maybe that someone might have towards a certain background or economic status that can kind of direct the care. At the health system level, there's access and capacity. And so, sometimes it can take a long time for patients to get in to see a primary care provider and then potentially to see GI. And so there's wait times of months, and COVID-19, we know greatly exacerbated this. And so, here at Ohio State, I know sometimes it could take up to 3 months plus to get a colonoscopy. At the national policy level, there's guidelines. We've recently gotten to or decreased from 50 to 45, but it took some time for all those guidelines to kind of make those appropriate changes. Insurance access and coverage. Sometimes some patients don't have adequate insurance access, and if they do, then the coverage might not cover some of these procedures. And then structural racism, and so these are institutions or regulations in place that are levied against people of color that affect their environment and therefore can affect their health. We can go to the next slide. And so some potential motivators or kind of solutions to kind of combat some of these barriers would be kind of strong patient-provider communication. And so mentioning colorectal cancer screening. And so I think it's not necessarily mentioning it at 45, but making sure we're, just probably even discussing it at 30, 35, and kind of planting the seed, understanding that it may take more than one meeting. Masculinity. And so this can kind of be a double-edged sword. And so some studies have shown that, there's the vulnerability of potentially performing a colonoscopy, lying on the table and kind of having the tube inserted in the rectum. But then there's also masculinity from the standpoint of, for a lot of African-American males or females, it's kind of like they have to get screened for their family. And so understanding that they need to take care of their own health to be able to provide and take care of their family. Centering the message of screening around family. And so studies have shown that there's certain voices that people might listen to, and number one is family, and then number two is the doctor. And so obviously when we speak to patients about colorectal cancer screening, the focus is on them, but I look at this as also we need to be focusing maybe on the family members as well, to get them, to encourage them to speak with the patient about getting screened. Another thing, possibly more transparent reporting of screening disparities at the state and local levels. And so I love that there was a graph earlier that Dr. Ubunto showed kind of the different colorectal cancer screening rates in the different states. I think this would be great if we had something like this at, in communities, city level, and it could really show patients, providers alike what these rates are, and that potentially can be kind of an incentive to kind of get in and get screened. Offering multiple options, as been stated before, the colorectal or colonoscopy has always been kind of this gold standard, but as we now know, again, mailed FIT testing is a great way to increase colorectal cancer screening rates, and it's all about kind of the shared decision making and doing what's best for that individual. We can go to the next slide. And so we spoke earlier about access and insurance coverage as being one of the barriers. And so some of you guys may know earlier this year, the Biden administration issued guidance requiring private insurers to cover colonoscopy when needed as a follow-up to non-invasive colorectal cancer screening test. So this is a great initiative to kind of stop the bills for patients that they get the FIT test is positive, now they need colonoscopy, then they shouldn't be penalized for that. And so hopefully we'll see kind of improvement in that arena. And so this is a study that was looking at barriers and facilitators to colonoscopy completion after FIT testing. And so the gold or the rate of colonoscopy completion after FIT testing, the gold standard is 80%. And so there was a Kaiser Permanente in Northern California that kind of underwent this initiative starting about 2010 to 2016, where they wanted to increase their colonoscopy completion rate. And so they instituted kind of several measures to kind of increase those rates. So they hired additional GI personnel. They created a central registry for normal FIT results. They standardized outreach through patient navigation, designated individuals to track the results, and then they followed up, made sure that those follow-up of the normal FIT testing was sent to GI. They mailed certified letters to non-responders to get them to send in those FIT testing, and they made sure it was a quality metric. And with instituting all of these things, they're able to increase these rates from 73% to 85%, so surpassing that goal of 80%. And so I just love this study because I think it shows that, with the right resources, the right infrastructure in place, we can, surpass even our goals. And go to the next slide. And so this is just a reminder, again, I think that Dr. Ubunto kind of covered this well earlier, but exclusions for Cologuard FIT testing is high-risk patients. So those with family history of colon cancer, personal history of polyps, IBD, those diagnosed with hereditary cancer syndrome such as Lynch syndrome, if you're having symptoms, blood in the stool, things of that nature, these are the patients that really wouldn't be best for them to undergo kind of these FIT and Cologuard testing. And then something I think we should always keep in mind is that explain to the patient that even though they're undergoing this FIT testing, if it's positive, they will need to undergo colonoscopy. And so I remember I had a patient that he didn't want to undergo colonoscopy, which is fine. And we got the FIT testing, but I made sure a point that we emphasized to him that if this is positive, we will have to undergo this colonoscopy. You can go to the next slide. And so ways at Ohio State that we're trying to change this initiative. We have free clinics, so offering care to patients in Columbus area that are uninsured. And currently right now, GI, we're trying to plug into these clinics, be able to offer GI consults there. We have a FIT kit initiative, as we were talking about earlier. Mailed FIT testing, or mailed FIT kit testing is a proven way to increase the colorectal cancer screening rates. And so we've created a multidisciplinary approach amongst primary medicine providers at the James, GI. We have navigators that have the initial contact and follow-up, patient information brochures. We've done a social media campaign. We've had endorsement by prominent figures in the community. And then we have partnership with GI to have colonoscopies for the abnormal fit testing. And so it's been going well so far. There's wellness events. And so we have health wellness events where we set up events where patients can come get blood pressure checks, diabetes checks. And there too, we have presentations going over screening, mammograms, colorectal cancer screening, and things of that nature. Colorectal Cancer Awareness Church Sundays. And so currently we're in the month of Colorectal Cancer Awareness Month. And so myself and a couple of providers have been going out to churches, speaking to really encourage people of color to go out and get screened. And so it's been an amazing experience, and looking forward to, we have a couple more Sundays left in the month to kind of reach the community. We have colonoscopy Saturdays, and so this was something that was started in the past, and through COVID, it was unfortunately kind of taken back, but offering colonoscopies for those positive fits for uninsured patients. And so we're hoping to bring this back and actually not only provide it in the month of March, but hopefully throughout the year at scheduled intervals. Next slide. And so here are just a couple of images again of us kind of out in the community. The upper left there is out at a wellness event. We have our inflatable colon, which is a hot people in the community greatly enjoy that. And then speaking at the church in the bottom left. And then here's an event that I did with Dr. Gray when I was a first year with Fight CRC, where we were at a Cavs game, kind of raising awareness. And so just great to be able to be a part of a lot of these initiatives. All right, and that concludes my presentation. I want to thank you guys for your time, and I'm open to any questions. Feel free to drop in the chat or send through Deb or American Cancer Society.
Perfect. Thank you so much, Dr. Akinyeye. We certainly appreciate your comments this morning and the stories that you shared. It greatly impacts the work we're trying to do, so we appreciate it. Our next speaker, let me introduce to you Dr. Linda Cummings. Dr. Cummings is a gastroenterologist at University Hospitals Cleveland Medical Center and Lewis Stokes Cleveland VA Medical Center, and an associate professor of medicine at Case Western Reserve University School of Medicine in Cleveland, Ohio. Dr. Cummings completed medical school at Washington University in St. Louis, Missouri, and internal medicine residency at Barnes Jewish Hospital in St. Louis, Missouri. She completed gastroenterology fellowship at University Hospitals Cleveland Medical Center and Lewis Stokes Cleveland VA Medical Center, during which she obtained a master's degree in clinical research. She is the recipient of the 2020 Helen Evans Mid-Career Faculty Development Award from the Woman Faculty of School of Medicine at Case Western Reserve University. She is a fellow of the American Gastroenterological Association and American Society for Gastrointestinal Endoscopy and the American College of Gastroenterology. Welcome, Dr. Cummings. We're glad you're with us today.
Thank you very much. I'd like to thank you for that kind introduction. Thank the American Cancer Society for this invitation to speak, as well as the other speakers and panelists, and thank the audience to talk about challenges to colorectal cancer screening today. These are my disclosures. I mentioned that I'm a gastroenterologist, and the reason that I put that on there is because some of the guidelines that I will be going through briefly generally tend to be from gastrointestinal societies. Next slide, please. These are my objectives. Next slide, please. So when I was putting this talk together, I remembered that I had done a talk on colorectal cancer for the internal medicine house staff about 9 years ago. And I pulled up the cancer statistics slide from that talk, and I thought it would be interesting to compare to 2022. So these are data from the American Cancer Society. And what you can see is that unfortunately, colorectal cancer remains the third most common cancer in the US in both men and women, although now it comprises about 8% of cases compared to 9% in 2013. Next slide, please. And so this is I'm sorry, can you go back one slide? And you can see that colorectal cancer also remains the second deadliest cancer in men and women in the US after lung cancer. Next slide, please. As the other speakers have emphasized, this is a preventable cancer. So the goal of screening is to try to impact these numbers of colorectal cancer incidence and mortality. Next slide, please. So I do want to briefly mention what is meant by average risk screening. And I think it's actually easier to talk about what average risk screening is not. So screening means that the person has no symptoms. So average risk screening is not applicable for people who have gastrointestinal signs or symptoms, such as bleeding, iron deficiency anemia, or abnormal imaging of the GI tract. It's not applicable in patients who have prior polyps, prior colorectal cancer, inflammatory bowel disease, or a high-risk family history. And one of the barriers that I've encountered when I've seen patients coming for colonoscopy, and I ask them about their family history as part of my routine questions, is that many families, especially families of color, don't necessarily want to talk about undergoing a colonoscopy. People may not even want to share with their family member that there is a diagnosis of colon cancer. At any rate, average risk screening does not apply if the patient has a family history of colorectal cancer and a first-degree relative diagnosed at age less than 60, or colorectal cancer in 2 first-degree relatives diagnosed at any age, or if there's a family history of a hereditary cancer syndrome. Next slide, please. So there are 2 main modalities for colorectal cancer screening, structured as structural tests, which are typically tests in which the colon is either directly or indirectly evaluated. Colonoscopy and flexible sigmoidoscopy are procedures where generally a patient receives sedation and the colon is visually inspected using a lighted flexible tube. And this has the ability to both detect and remove polyps. CT colonography is a structural test which involves drinking a bowel prep. The patient undergoes a specialized CT scan with insufflation, and then 2D and 3D images are generated of the colon. And you can see in that slide, there's the corresponding endoscopic finding. And then the second category of tests are stool-based tests, which include fecal immunochemical testing, which tests for the presence of hemoglobin, and fit fecal DNA, which was described earlier, also called a multi-target stool DNA test. I didn't put on this slide the fecal occult blood testing simply because some of the groups have pointed out that FIT is superior to fecal occult blood testing. I would mention that the guaiac-based FOBT test does require 3 samples, some dietary restrictions, and some restrictions in terms of restricting from certain medications such as NSAIDs. Next slide, please. So in the interest of time, I'm not going to go through this in that much detail. These are colorectal cancer screening guidelines for average risk individuals from different groups. My slide does differ a little bit from Dr. Ubunto's slide because I do include the American College of Gastroenterology, which is part of the multi-society task force, but did put out their own guidelines in 2021. I would mention that high sensitivity FOBT and colon capsule on this slide are grayed out simply because some of the groups do not recommend them. Next slide, please. So when to start and stop screening has been an area of active discussion in the past few years. As you can see, these groups generally are recommending starting at age 45. And the Multi-Society Task Force did publish an update earlier in 2021, stating that they wanted to start screening for all races at age 45, whereas the previous MSTF guideline from 2017 had said to start at 45 in African Americans. In general, there's strong evidence for screening between age 50 to 75, and that's in all of these groups' guidelines. And beyond age 75, in general, it's an individualized decision. I would say that after age 85, in general, screening is not recommended because there's an increased risk of dying from other causes. In general, we think of an individual who may be a candidate for screening when we think that they may have a life expectancy of at least 10 years. The benefits of removing polyps are delayed by 7 to 10 years after screening. Next slide, please. So I did want to mention, especially since this forum is providing CME from the American Academy of Family Physicians, that they actually came out with a statement in 2021 saying that they felt the evidence is insufficient to assess benefits and harms of screening for adults who are not yet 50. And so their main concerns were that some of the rationale for starting at age 45 is based on indirect evidence from modeling studies, and they really want to see more data before they would support starting at age 45. Next slide, please. So I wanted to switch gears a little bit and talk about the uptake of colorectal cancer screening in the US. And this is from the 2020 Behavioral Risk Factor Surveillance System, which is a survey which asks individuals about receipt of colorectal cancer screening, whether it's colonoscopy, FIT, sigmoidoscopy, FIT DNA, which is also the multi-target stool DNA test, or CT colonography. So 2020 was the first year that they included all of those testing modalities in their survey. And as you can see here, 72% of adults aged 50 to 75 were up to date. This does not include people who were less than 50 because the USPSTF guidance did not come out until after the survey. Next slide, please. So I thought it was interesting to pull some data specifically looking at Ohio and West Virginia. These are slightly older. They're from the same survey, the BRFSS. So through 2018, you can see that screening rates in Ohio and West Virginia were slightly lower. The red lines refer to women and the blue lines refer to men. So the screening rate in women was approximately 68 to 69%, and that in men was lower at 65% in 2018. Next slide, please. And then if you look at the screening rates when they're divided by race and ethnicity, you can see that screening rates are much lower in non-Hispanic Blacks and Hispanics compared to non-Hispanic whites. Next slide, please. And looking further at age, you could see that individuals who are 50 to 64 in either state are less likely to receive screening compared to individuals who are 65 to 75. Next slide, please. So I thought this was a very striking slide. It's looking at the insurance status of people who receive colorectal cancer screening. And you can see that those who are uninsured are much less likely to receive colorectal cancer screening, with the rate being less than 50% in both states. Next slide, please. So tying into that, I came across a very interesting abstract, which was just put online earlier this month, in which the investigators distributed a food insecurity screening tool at 9 National Cancer Institute designated cancer centers. And they found that food insecurity was inversely linked to being up to date with colon cancer screening. So basically, if you had food insecurity, you had a 30% lower odds of being up to date with colorectal cancer screening. And I think this likely reflects a population that has difficulty accessing care due to financial barriers. Next slide, please. So when we think about financial barriers, I know the other speakers have already spoken about this in much greater detail. And these are just some of my thoughts about what types of barriers a patient may be facing. If the patient has elected to have a colonoscopy, they face possible loss of work. Some people are able to prep even though they're at work, although I think this is rather unusual. Obviously, they can't be working on the day of the procedure. And then depending on what their work schedule is like, I've had patients who do a night shift and they're not able to work that night. Sometimes the cost of the prep can be quite high, depending on what the prep is, or in that patient's household situation, they just can't afford the prep. And then if the patient receives sedation, which is typically the standard, having a ride, that person also may be missing work. So there are a lot of barriers that a patient may face in terms of undergoing a colonoscopy. As Dr. Akinyanye mentioned, the Affordable Care Act waived coinsurance and deductible for colonoscopy, sigmoidoscopy, and FIT. And then I wanted to bring up this concept of cost sharing, which I know Dr. Akinyanye mentioned earlier. So for many years, Medicare had a colonoscopy loophole, meaning that if a Medicare patient underwent a screening colonoscopy and they had a polyp removed, the procedure was then classified as therapeutic and no longer screening, and the patient ended up subject to a surprise bill. So in 2020, Congress passed legislation to phase out coinsurance between 2022 and 2030. So this has been the result of many years of advocacy by different GI groups as well as other groups. And then in January 2022, the Biden administration clarified that private health insurance must cover colonoscopy after a non-invasive screening test, because that's considered part of the screening process. And that is to start May 31st, 2022. Unfortunately, this does not apply to traditional Medicare or Medicaid patients. Next slide, please. So I wanted to focus in the last few minutes on efforts at university hospitals to improve the uptake of colorectal cancer screening. And these slides were provided by Ashley Matthews of the Digestive Health Institute. Next slide, please. So in terms of community outreach, we've had some outreach initiatives at the system level, including reaching out to federally qualified health centers last year, in which we provided kind of a process for them to more easily send us screening referrals for colorectal cancer, and we helped to navigate patients through getting the procedures scheduled. We also had some efforts to educate the public about FIT testing in terms of following up on results and helping to navigate those patients to get scheduled for colonoscopy. I would say that over the past few years, my hospital system has also implemented a method by which even patients who are not regularly following with a primary care provider can call an 800 number and request a colonoscopy. They do have to go through some screening questions, but they can get scheduled for a colonoscopy that way. And then finally, we have some consumer seminars and health education fairs, which have been held at our community hospitals. That's a picture of our inflatable colon. Unfortunately, with COVID, a lot of these things have been put on hold. Next slide, please. And then on the patient education and marketing side, we've developed some patient education materials on colorectal cancer screening options, medical illustrations, which I used some of these earlier today. And we've standardized our colonoscopy bowel prep instructions. There was a live colonoscopy that was aired a couple of years ago to raise awareness of colorectal cancer. And then we have some content marketing that's in print, blog, and on Facebook. Next slide, please. So I just wanted to share this position statement that the Digestive Health Institute at University Hospitals came up with during the COVID pandemic. So this is kind of small print, but basically for average risk individuals, they can choose home-based testing, which could be either FIT DNA testing or FIT test. Versus if they have a preference for colonoscopy, there's a mechanism for an open access colonoscopy. Next slide, please. And this is the other side of the position statement, which is for high-risk individuals in which the stool-based testing is not appropriate, in which case the patient could decide if they would prefer to have a consultation before a colonoscopy to discuss the procedure. Next slide, please. And then at the end, I just wanted to share with you this health system dashboard provided by Exact Sciences, which tracks our uptake of the use of FIT DNA testing. And you can see that the timeline started in January 2020, prior to the pandemic. There's a huge drop off in April when there was a shutdown. And you can see that after April of 2020, there was a uptake of FIT DNA testing across the system. And some of those months you see like over 2,000 orders placed for FIT DNA testing. Next slide, please. And that's the end of my slides. I'd like to thank Chesley Cheatham, Ashley Matthews, and John Dumage from University Hospitals, as well as the American Cancer Society. And I'm happy to take any questions in the Q&A.
Dr. Cummings, thank you so much. We're so grateful that you're with us today. All right, the next thing we're going to do is we'll take a look at a poll question. This will be our fourth and final poll for this morning. Please notice on your screen, we have a question that says, based on your observation of those you serve, which populations or groups face the greatest barriers to colorectal cancer screening? Please choose any. You're welcome to make multiple choices. And if you don't find a group represented in the boxes, please feel free to put them in the chat. We would really like to hear from you. If you please make your selections. And as I mentioned, if you see something not represented, please pop that in the chat for us. I'll give you just a moment to fill out the poll. And while you finish that, let me introduce to you our next speaker. Our final presenter this morning will be Katie Lamb. As a lifelong resident of West Virginia, Katie has seen the health struggles prevalent in the area. She's committed to improving the quality of health in her home state. Katie joined the West Virginia Health Network, where she works alongside practices and healthcare facilities across the state, using population data to identify need and turning that data into actionable initiatives. Additionally, Katie is dedicated to improving health equity while increasing cancer screening rates for breast and colorectal cancer, preventable disease through increased immunizations, and addressing chronic disease and food insecurity. Katie, thank you so much for being with us this morning.
Thank you so much for having me. Thank you to the American Cancer Society, as well as my fellow panelists, and of course, the audience in attendance today. This is a wonderful, important discussion, so I'm happy that everyone has taken time out of their day to join us. My involvement with the American Cancer Society began with the opportunity to serve as a part of the hospital system's capacity building communities of practice, along with my work at the West Virginia Health Network. Together with great community leaders, hospital outreach department leaders, and of course, specifically calling out Shauna Schaefer with the American Cancer Society, we work to collaborate and incorporate cancer screenings and prevention tactics into our hospital mission and increase quality standards to increase those screenings, specifically focusing on colorectal cancer screenings. Many of the other guests today have discussed some of the options in detecting colorectal cancer. Actually, there you go, thank you. Yeah, there you go, first slide. You know, both in precursors as well as the disease itself, along with barriers that people face to increase those rates. What I would like to focus a little bit on today is the data, specifically what we have, what that represents, how we can use the data, why we collect it, and do we have all the answers? You know, what are the next steps? First, of course, you know, our main goals with data is we want to have reliable, accurate, and provide relevant information. We want to use that accurate information to be able to plan our strategies and really focus our resources. We want to be able to use our data of the population to then narrow our scope and gain understanding of that population, and then use that information to develop actionable efforts at the patient level. Next slide, please. Okay, turning our attention specifically to the data that our collaborative focuses on a monthly basis. We narrowed our efforts to 5 specific clinics within the West Virginia Health Network, all of which are in West Virginia. 4 of the clinics that you see here are within or near a city, while 1 is in a rural setting. Okay, the West Virginia, actually back up 1 slide, sorry. Okay, the West Virginia Health Network uses a population health platform. It's called Healthy Intent, which is a Cerner product. This allows us to look at the Medicare and Medicaid data sets for our practices. We do have feeds coming from their EMRs specifically, as well as claims information from the payers. In this chart that you see here, we do focus on the numbers of colorectal cancer screenings performed, our numerator, versus the population count, consisting of those patients that qualify for the measure, or of course our denominator. In terms of complete count, this does include colonoscopy, flexible sigmoidoscopy, FIT tests, Cologuard, and other DNA testings. Looking at the percent completion rate, we can track trends and assess any efforts to increase screenings. We do see a change in our population somewhat from month over month. In the complete count column there on the far right is how we kind of track that and take a look at that. It is indicative in some cases of patients possibly moving practices, moving payers. In short, this is just to note that our population is dynamic. Next slide, please. Of course, for trending purposes, you know, as a part of this collaborative, we do want to consider those quarterly median and average percentage, you know, to consider those central tendencies. Next slide. Okay, this is our trending view for the percent complete by clinic. So as you see here, we do have an outlier there to consider, that blue line down towards the bottom. You know, we'll focus on this a little bit more later, but simply looking at these clinics as they compare to one another is not necessarily fair. Given the different locations, the levels of access to care, and those types of things, we need to keep that in mind when looking at these trend lines. The trend view does allow us to question why we are seeing the movement we are. Is it indicative of a change in a data set? Is the population moving, providers, payers, an increase in the data into our population health platform? Or is it the true increase in screening performance? You know, we have to keep all of these things in mind when we're looking at our numbers. In this case here, you do see a bump for Clinic 5, that blue line down at the bottom. You do see a bump at the beginning of this year that actually does correlate to some increased initiative and encouraging FIT test usage. As well, the dip in Clinic 1, the lighter blue line towards the top of your graph, the dip that we see there, as well as the spike in the other 3 clinics below that, are actually correlated to an increase in data into our population health platform. So again, very important to take note of the rest of the picture, what else is going on at these specific data points. Next slide, please. Okay, so we like to drill down as much as possible when we have the information available. So from the clinic level, we then take a look at the provider level of our 5 clinics within our collaborative. Of course, we do report this on the individual provider level to those specific clinics, but of course, I've just shared here today, you know, a subsect of those with a keyed approach. We use this information as an opportunity to share best practices, look at an individual provider that is maybe performing very well within the same clinic, within the same location, as possibly a provider that may be struggling. Share best practices, education, things like that, and some good old-fashioned competition between physicians as well. So that comes into play. Physician names, again, are shared with the clinics so they can use that information accordingly. Speaking to this as well, I don't have a slide to note this, but on a quarterly basis, we also drill down to the patient level. So from this screen, we can drill down to the patient level and provide each practice with an actionable list of patients that are due for those colorectal cancer screenings for scheduling. Next slide. Okay, some of the changes that in requirements and reporting and collecting data that are new or coming our way that some may or may not be aware of. The NCQA has added race and ethnicity stratification for 5 different HEDIS measures, colorectal cancer screening being one of them. So why are they looking at this? Quite simply, to keep in mind some of the things that we're discussing today, to highlight those disparities and come up with a plan on how to address those gaps. Conversely, we can use those that are top performers to possibly share some best practices, assuming that they're relevant to the different areas. Next slide, please. Okay. Other requirements and other changes to consider is specifically how is race and ethnicity collected. And when I speak to this, I'm mostly speaking to, how is that information entering into our databases, EMRs, things like that? Does it come from a file from the state level when a specific member signs up for Medicaid, for instance? Who assesses that race and ethnicity? What happens if the patient doesn't disclose that information? Additionally, some of the EMR vendors don't have the capability of collecting this information and storing it in a discrete field. So speaking to the IT mapping, a great collaboration with your IT staff and vendors is really important here to make sure that we're capturing the information that we need to track and that is important. One takeaway I want to offer and keep in mind that I've touched on throughout is the data isn't always what it appears. We need to understand the context around the data. Okay, so here are the numbers, but what does that mean? I think Dr. Kamal at the beginning touched on a great note. We always need to remain curious. Here are the numbers. What else do we need? What does this mean? And what are our next steps to truly decrease these barriers in health equity and colorectal cancer screenings? Next slide. I think that might be it for me. All right. I want to thank everyone for having me today, and I appreciate any questions that anyone may have.
Katie, it's been a pleasure. Thank you so much for presenting. Thank you so much for sharing. We have just had such a tremendous panel today. So thank you all very much. Right now, we'd like to share with you a message. This is from the American Cancer Society Ohio West Virginia Board Chairman, Chris Kipp, and Chris is the winner of the American Cancer Society's distinguished St. George National Award. So I present to you, Mr. Chris Kipp.
Hello, and welcome to today's Cancer and Health Equity virtual series. I'm Chris Kipp, the Executive Director of Clinical Services and the Chief Nursing Officer at The Ohio State University's Comprehensive Cancer Center, James Cancer Hospital, and Soloff Research Institute. I'm a proud volunteer, leader, advocate, and donor for the American Cancer Society. The American Cancer Society and the James Cancer Hospital have had a long history of collaboration. I'd like to highlight a number of our current projects. One is in the area of colorectal cancer research. ACS has funded the work of Dr. Fred Tabung. Dr. Tabung's research and treatment involves the role of diet and lifestyle among patients with GI tract cancers, with the goal of identifying potential biological pathways linking dietary patterns and cancer outcomes. An additional area of collaboration with American Cancer Society is Researchers. Researchers is an exciting program that shines the light on the incredible scientific discoveries made by women. The program empowers women leaders to support ACS's National Research Program, which funds some of the brightest female minds in cancer research, including right here at the James. As a result of funding raised through Researchers, the Summer Health Education in Oncology, or SHE program, will be held at The Ohio State University in the spring of '22. SHE is led by Cancer Centers in partnership with ACS and is a 2-week virtual program introducing high school juniors and seniors to the wide range of cancer-related career opportunities and experiences. I'm excited to share another collaboration, the first of its kind, the LGBTQ+ and Cancer Care Project Echo Pilot, which will launch in May of '22 and will involve education and planning with 5 states working together to learn about and address the overlapping and common barriers that exist in the LGBTQ+ community in accessing primary care, cancer risk reduction, cancer screenings, and survivorship care. Finally, Turning the Page on Breast Cancer is a statewide initiative that addresses the disparity of breast cancer in Black women. Which brings us to our event today. One of our serious challenges facing the cancer community, and that the pandemic has amplified, is the inequity surrounding cancer preventative screenings and access to care. The Health Equity and Cancer Virtual Series from the American Cancer Society brings together cancer experts, including many from Ohio State, to address cancer disease burden for several cancers with a focus on addressing disparities in prevention and early detection. Thank you for participating in this important conversation.
Terrific. Thank you so much to Chris Kipp. We appreciate not only his leadership and his support, but we appreciate his comments this morning. In closing, I hope that you can join us for our next virtual forum in the series, where we will be discussing health equity and HPV cancer vaccination. Immediately after this session, you'll be asked to complete a post-event survey. Completion of the survey is required to receive continuing education credits. You'll also receive a post-event email with the recording of this session and the survey link. We want to thank you again for joining us today. We want to thank you so much for your commitment to fight for a world without cancer. We hope you have a wonderful day.